Hello, my name is Kafui Dey, and my guest is Mr. Anthony George Laing, one of the pioneers of plastic and reconstructive surgery in Ghana. But before the conversation, let me give you some good news. If you send money back home to Ghana, you need to hear this. Lemfi is the app to use to send money from the UK, Canada, Europe, or the US straight to Ghana with zero transfer fees. You can send directly to bank accounts or Momo, and your people back home receive it within minutes. The exchange rates are competitive, and the app is secure and safe to use. And here's a bonus. When you sign up and use my referral code Kafui, you get cash back on your first qualifying transfer. Plus, every time you send money, you earn reward points you can use to transact later. Download the Lemfi app now and use my code Kafui when you sign up. Mr. Anthony George Laing, it's a pleasure to meet you.
Pleasure to have me.
What's your day been like so far?
It's been a busy day. I've had to introduce plastic surgery to the final year students. They come in groups, 13 to 15, 4 consecutive weeks. I take them on a Monday and a Tuesday, and a colleague takes them on a Wednesday. It's to give them an idea as to what plastic surgery is about and some of the misconceptions about the whole specialty. And we encourage them to think with the lecturer as the lecture it's going on, rather than be looking at the phones, YouTube and things like that. They should follow what the lecturer says so that they will understand better when they go back. The reason being, there are so many attacks or ways of dealing with any particular problem in plastic surgery. And to a novice, if you don't understand the whole subject, you just be confused, because for one problem, there are 10 approaches. Which one do you take? You're inexperienced. So we try and sort of reduce everything to an understandable and easily assimilable form, such that their reading becomes more meaningful and they can get some sense out of what is not, in the textbook.
Indeed. Mr. Laing, so can you break down what plastic surgery is for an intelligent 16-year-old?
A 16-year-old, yes. I am sure 16-year-olds are intelligent enough, but plastic surgery, the word plastic itself comes from a Greek word which means shape or form. It means you're dealing with an object which has dimensions, either small, big. So our duty is to correct either congenital, that things you are born with, or acquired defects and deformities.
What are the most common congenital defects that you correct?
In Ghana, cleft lip and palate, where you are born with a gap in the lip, sometimes combined with a hole on the roof of the mouth. Duplication of thumb. People are born with the thumb, instead of it being single, it's split. And there are various degrees of splitting. It could be just the distal or the end bit of the thumb, or it may be split all the way down. Syndactyly is another common one, where the digits are fused.
So you have maybe 2
yes,
fingers.
And there are various combinations, either this or that, or they may be fused, or they may be fused distally with gaps at the proximal part. Okay. So many combinations. This is for the hand. But if you take cosmetic surgery, a lot of people are interested in that, both 16-year-olds and fully grown individuals, where somebody's figure it's altered, either to enhance a particular part of the body, the size, or to reduce it.
What are the most common cosmetic procedures that you do?
Breast reduction.
People think their boobs are too big.
Breast reduction, yes.
Okay.
I think the next one, perhaps almost the same league, is liposuction. Liposuction. Basically, it involves removing fat from some parts of the body and transferring it to another part to enhance either the bulge or the shape or to alter it. But one has to be very selective because it's not suitable for every person. If you've had multiple operations on the abdomen, for instance, the anatomy has changed, and it's quite easy to lose your way or to go the wrong way and go the wrong way. Let's say you puncture the abdomen and enter the cavity. If you don't see it at the time, you may kill your patient. And we've had events like that. Or you may have an infection of the whole area and you lose it. Literally, it sloughs off through infection. And then you regret. The important thing is to go to the right person so that the right thing is done with the right instrument, with the right environment. If not, you are in trouble. But as I say, congenital or acquired. Ghana is noted for a lot of accidents. So quite a number of young male adults have had an accident and they have either lost a little bit of skin or a large chunk of bone with skin or muscle lost in some part of usually the lower limbs or the arm, or they may have a very bad injury to the face where a chunk of tissue is taken out and requires replacement by plastic surgery. And of course, people with cancers also, sometimes we help them out. The ladies who have cancer of the breast, if they are caught early, you can remove the tumor and then refashion the breast so that at least they are comfortable when.
Where are you getting the flesh from to refashion the breast?
Oh, ways and means. They've got spares.
Ways and means.
We've got spares. Sometimes you may have to reduce the size of the one you're leaving behind to match the one that has had the tumor removed.
Okay.
But we can transfer tissue from one part of the body to the other.
Which part of the body? I'm curious.
Anywhere.
Okay.
The bum. The bum.
The bum can now become part of your breast.
Yes. Or we can use, there is a muscle at the back here. We call it by this funny, latissimus dorsi. People who throw javelin depend on that for their success, you see. You can take a paddle of skin with a muscle and transfer it to the front. You do it either with we call it a braid, still attached, or you can free it completely. Free completely, and then when you bring it to the area, you do what we call microsurgery. You join out the blood vessels to recipient blood vessels.
How long can some of these surgeries take?
Ooh, it takes a very long time. Those who do it regularly, obviously have an advantage. They can do it maybe 3 or 4 hours, you see. But someone who does it not so frequently may take about 7 hours.
And you're standing all the time?
Well, sometimes you have to sit, but quite a number of cases are done standing. Yes, unfortunately.
So you need a lot of stamina and strength.
If you are doing a hand surgery, for instance, usually best to sit because you have to rest your elbows. Particularly if it involves using fine instruments or using the microscope. You have to be steady, so that we are seated. But some of the other cases where you have to perhaps move around and see whether things are in the right place, etc., sometimes you have to stand,
What's been your longest marathon surgery?
That was on the coach of Kotoko, Zito.
Coach Zito.
Karim Zito.
Okay.
I don't know, you must have seen in the papers. This was quite early in the, maybe late 1997, 98, or perhaps later, but it was a while ago. He was assaulted and he nearly lost the whole hand. The hand was hanging by his teeth. The assaulter, they wanted to pinch his phone. Wow. So I had to put the whole thing back. I did it, and it took me about 7 to 8 hours. You have to do the tendons, you have to do the blood vessels and the nerves. Usually you do the back of the hand first, because the structures of the front are more delicate. So if you do this first, while doing this, you may disrupt what you've done.
Yeah.
So we usually do the back. Sometimes involves shortening the bone so that you can freshen the margins of the wound.
Okay.
And then do the upper. But this was a clean cut, luckily. So it was mostly a question of joining up the bones first, and then doing the back, and then the front. It took me about 7 to 8 hours.
How many were in the team?
Oh, I was the main surgeon, and I had an assistant. In fact, the assistant wasn't even a plastic surgeon, a trainee. So I did most of it. Occasionally, we ask a trainee to do a particular procedure while we watch, so that they pick up the skill.
What's it like when you are doing the surgery? Are you playing music?
Sometimes, just to relax, you do.
So what kind of music do you listen to when you're doing surgery?
I personally prefer something which is not too bumpy.
Okay.
So
no
literally
rock
dulling.
music. No rock music.
Literally dulling you.
Okay.
Serene.
Like classical?
Yes, it may be classical, but sometimes some of our local things can be interesting.
Which ones?
Let's see. Trami China Mumbo Komobi.
Yes. Why are you doing that?
It relaxes you. If not, you can easily fall asleep. Usually, it's the bystanders or the assistant. If it's not actively involved, you can easily fall off.
Yeah.
But that's the way it goes. Of course, you have your scrub nurses. You have people who set the table up and move the microscope from here to here, adjust things for you. People who go and collect the blood from the recovery room and bring it when the time is due. There are a lot of people who play a part, even though sometimes they are forgotten. But it's always a team approach that we use for our cases.
What's your most terrifying moment during a surgery?
It's someone who was stabbed in the neck. And it gone so deep. The spine is in the way, of course. And you are afraid that gaining access to the depth, you may injure some important structure. And the patient too is bleeding. It's difficult to put a tourniquet around the neck. That's the important thing. Other parts of the body, you can put a tourniquet to stop blood flowing so that you can work, not in an inkwell. You can see things you're working on. But this is a very difficult case. Patient is bleeding all the time. Sometimes we have ways of diminishing bleeding without using a tourniquet. The anesthetist can lower the blood pressure for you.
The person who puts you to sleep?
Yes. And sometimes, if it's not done properly, you starve some of the cells and you end up with dead cells in your brain. Or they can tilt the table such that the head is in an upward position, the rest of the body. As though you're standing,
yes.
There's less pressure there.
Exactly.
And sometimes we go for the main artery supplying the area. Access it and clamp it. You stop flow. But this time you're working directly on the vessel, so that at least you can do the delicate part of the operation. So it can be scary. When blood is coming, even from a small artery, it spews out.
You see it coming out like that?
Oh, yes. So you can imagine a bigger vessel.
Yeah, around the neck.
It literally can shoot up to the
Like a
roof.
fountain?
Yeah. Yeah, fountain of blood.
I want to see that.
Yes, I think this is the case that I remember because it was a hefty chap. And working in that area with the tourniquet was tough. You know, whether or not you could even get the verses, what was the fear? You know, if you clamp the wrong thing, you've put a break in the nerve. The other one, sometimes while working, all of a sudden you discover, am I working on the right part of the body? And it's happened before.
Mr. Laing.
So it's a thought sometimes that goes through your mind, but before operations, just as we were talking, the initial stages of checking the patient's name, age, and sex, and all the investigations done, make sure that an investigation belongs to the patient. Because sometimes you can have accidental contamination of patients with somebody else's results.
Wow.
And the time may come when you have a problem, you want to refer to the results, the laboratory. So if you don't check the name, you may look at the wrong one and make a wrong decision.
You mean you have the paperwork in the operating theater while you are doing the work?
We'll have the patient's notes. Of course, these days we go in digital entry.
Okay.
But all the investigation should be in theater. Sometimes, it occurs to you and you say, recheck. Maybe the patient is bleeding. So you say, can you check the blood test that they did? Was there anything abnormality that perhaps we overlooked? Were the platelets there in the right numbers? Was the clotting time correct? That sort of thing. These are things that occur when things are not going quite the same way. So you need to recheck. Was everything in good shape before it started?
I'm wondering, has there ever been a situation where there was like panic in the room and you could feel it, you could hear it?
Panic?
Yes.
A surgeon usually doesn't panic.
Maybe
not someone who's been through for over, I qualified in 1967.
Okay, so next year is 60 years. Wow.
You don't panic. Usually the young ones, they may, but it's something you get used to, not to lose your cool. When it comes to that kind of situation, you usually make sure that everybody in the area is quiet, no distractions, you see. So perhaps the music may stop,
Yes.
or conversation between those observing should stop, so that at least the surgeon can have a good, clear mind to decide what to do. But panic, no way. We don't panic.
What about arguments? Can there be arguments among the team while you're working on something?
There is always a senior person. I mean, if I'm operating on a patient, I don't expect my resident to tell me that what I'm doing is wrong. If I don't know it, I have to look up before theater. Okay. The same thing we try to teach our residents. They should prepare themselves for the operation. But we do. I always, something I haven't done for a while, if I have it, I brush up the anatomy before I go. So that I know exactly. You can't remember everything all the time.
No.
It takes a few minutes just to revise something. So it gives you the confidence to do what you're doing. Particularly if you've done it before.
Yes.
Once you start, it comes like riding a bicycle.
Yeah, muscle memory.
Once you can balance, as soon as you climb on it, there you go.
You're gone. It's a fascinating kind of work, and I'm wondering just about the odd stuff. Have the lights gone off on you on the surgery before?
Oh, yes.
What?
It happens now and then. We are supposed to have a lamp, usually charged, so that in such a situation you can use it. But sometimes it doesn't happen. And you literally have to wait till the light comes back.
Can that be long?
Oh, not usually long. Sometimes on and off, on and off.
Meaning you do so things in the middle of
you start again and the light goes off, operating lights go off. So far we haven't. We haven't lost any patient because of that situation, but it can be irritating, Usually, when they're going to do any repairs on electrical, they do warn us.
Yes.
And we are quite prepared. But occasionally, it just happens, and you just have to keep your cool, and perhaps you put a damp swab. By a damp swab, I mean a gauze that is moistened with saline, salt. You just lay it gently on the part you're working at. It stops any bleeding until the lights shine again, and then you can
good to go.
resume. You know.
What's your favorite surgery?
As I say, working on the nose has been one of my favorites, in that I did a lot of that.
Why? Why do you think you did a lot of nose jobs?
I worked in Ireland for 3 years. In the national game, it's like hockey, but the bat is slightly like a paddle.
Is it like lacrosse?
It's not, lacrosse is for the women.
Hurling.
But it's a very dangerous implement that they use, and they get injuries to their face and noses. So you get people with crooked noses and stuff. And the other thing, the Irish people are very fond of their liquor. Weekends, they get stewed up in alcohol, they get involved in fights and falls, and they come in broken bits, noses and zygomas and all the rest.
Where's the zygoma?
This bit of the bone that
on the cheek.
The cheekbone.
Okay. Broken.
And knock on the well, perhaps displace or break the zygoma. So I did a lot in that area.
Okay.
So it's when you have a crooked nose and you straighten it, and the patient looks at us, this is me. they are quite happy. Other times it can be a bit dodgy, where you have to reshape a nose by removing tissue, throwing away something, not leaving things as they are, not rearranging things, but actually reducing a nose, the size.
You're taking matter out.
Some people have got noses that look like a beak.
Yes.
And if they are worried, they may ask for reduction of the beak, the bit that sticks out.
Yes.
So you're going to remove parts of the anatomy to throw away. So if you don't judge it properly, then you're going to remove more than it's there. You end up with something the patient didn't ask for.
Have you had some dissatisfied customers? I don't like this nose. I mean, what happens if somebody says, I don't like this nose?
You always have people who may not be quite happy with the results. A lot depends on how you select your patient. A patient that comes to you with a deformity, you have to make sure it's quite right in the head. If they have a bad motive, whatever you do, they will never be satisfied.
What's an example of a bad motive?
Let's say a lady comes in, she wants a breast reduction. The lady is married to a chief executive somewhere who's got a very nice, beautiful blonde secretary who's well endowed, mammary glands-wise. So frequently, the chief executive has to travel with the secretary, go out together to do some work. So the wife doesn't get a chance of enjoying the company of the chief executive. And she gets the impression that perhaps there's something going on, and perhaps if she could modify her breast to look like the breast of the secretary, things will be different.
That's a bad motive.
So you do the operation. My man is still going around with a laptop with the secretary. So
it wasn't the breast at all, after all.
And she's never satisfied. So, generally speaking, you want to be able to select the right patient. Literally, quiz them to see what is in their mind, the motive behind the request, and see whether it's a suitable case. If not, then you're going to have trouble.
You've been talking about breast reductions. Do some people come asking for breast enlargement?
Of course.
Is that possible?
Of course. Of course. You know, as you age, certain organs atrophy or waste. Say somebody who's delivered or produced a lot of children and all of them maybe were breastfed. Sometimes they end up with the glandular tissue reduced in size, but the envelope, it's so redundant. So the breast hangs like a sock. Okay, so they may come for the breast to be reshaped. What you do is to leave whatever glandular tissue there is and tighten up the cover.
Okay.
You redrape it.
Is that what we call Bobby stand in Ghana?
Well, so it stands, you know.
It stands. Okay.
But there are people who come and you have to add something to it. It may be the patient's own tissue, or it may be a prosthesis.
Like a artificial supplement?
Yes. So sometimes we use a muscle.
Okay.
I've talked about latissimus dorsi. There are other areas that you can borrow from to enhance the volume.
Okay.
If that is not suitable, then the next thing is a prosthesis. It's usually made of a substance that that doesn't evoke tissue reaction.
Okay.
Or there is very little tissue reaction. Silicone is a very good example of the material they use for. We call it implants, breast implants, and they come in all sizes and shapes, you see. So you select the appropriate one, the volume and size and shape, and then you make an incision, a cut, and usually bury it under the muscle if possible. It's deeper than just underneath whatever breast tissue there is.
Okay.
So you put it in place and you stitch it up. That enhances the volume.
Has it got an expiry date?
Oh, you have to check the expiry date, but there are people who have had it for maybe 15, 20 years without it. Other times they have problems.
Okay. Can it
And one of the commonest problems would be a wall forms around it. We call it a capsule. And when it contracts, when it shrinks, the breast, instead of looking the way it should, slightly droopy and pointing in a particular way, becomes globular. Yes, rounded up. And then you have to go in and literally bivalve it like a cell.
Okay.
Or you may have to remove one surface of the ball. Okay, we call it capsulectomy. If you are just bivalving it, capsulotomy. Capsulotomy. The removal of the one surface of the wall or of the globe, that will be capsulectomy. Ectomy.
Okay.
Tommy by itself is different from ectomy.
I'm just curious, for men, do they come asking for you to increase the size of their penises?
Some psychological patients do. In fact, people, sometimes it may be a university student who's got some funny idea that his John Thomas is not quite the appropriate size for him. And you look at it, he looks normal, yet he believes strongly that it's small, you see. There was a joke somewhere in, I think it was in Kenya. The Minister of Health was a female.
Okay.
And there was a story going around that some men are having their manhood enlarged by a doctor somewhere in Kenya. So the question was put to this Minister of Health in Parliament. Is it true that some men are having their apparatus enlarged? You know, amidst laughter, he said, well, she hasn't heard of any such thing. And then another question. If it's true, even though you said, if it's true, then all the women should wake up and go on demonstration because they are going to be hurt one way or the other. You know, they were joking about it.
In Parliament, yes.
There are ways of helping people who have erection difficulties, of giving help to them. But that involves implanting or putting into the apparatus a tube that you can expand. It's usually got a bulb or reservoir So you have to squeeze the reservoir and the fluid enters this
And then it's
particular
expansion.
and expansion just to promote an erect phallus, you see. But that's quite different from what the layman thinks. Having something added, a flesh.
Yes.
No,
So you
no.
can't. Although you can take flesh from a thigh and put it on a breast, you cannot add to the size of the penis.
You can graft a diseased phallus.
Okay.
Let's say through infection, you've lost a bit. You can graft it.
Oh, okay.
It's different from trying to enhance the size of using muscle borrowed from,
At all.
It's I think it's a waste of time, and only the, shall we say, the innocent will allow themselves to be fooled.
It's a fascinating world of surgery. And now I want to take it all the way back to the early 40s, because you were born in 1940. What are some of your earliest memories as a child in the 40s?
The first experience with attending the kindergarten, where you have to leave home, your mother, and say, today you're going to kindergarten. I remember being carried by, I think it was my mother, amidst protests. I was being taken to kindergarten, and the kindergarten was just behind the church, St. Cyprian's Church in Fountain Newtown. It's the back of the church that they have a little space there. We learn that we play around and learn. There will be nursery rhymes and things.
Yes.
I was protesting. I knew exactly what I was wearing. A blue and a white. The white top had a rectangular bit like a sailor. And I remember kicking and doing all sorts of things. The first day I was being sent to kindergarten.
How old would you have been?
I was around about 2.5.
And you can still remember that?
Yes.
Wow.
Very well.
This is Kumasi?
Kumasi.
Okay. But you were born in Dunkwa?
I was born in Dunkwa. My father was transferred to Kumasi. Early 40s.
What was your father doing?
42.
What was his profession, your father?
My father was an educationist. So at the time, I think he was a headmaster, and he had been promoted to a supervisor of schools. So they moved him from Dunkwa to Ashanti. He initially was supervisor of schools for Ashanti region, you see. So, of course, we followed. And everywhere he went, of course, we followed. The other one was one of the memories. At one time, I think I must have been in class 2. One Sunday, I wasn't able to attend church service. And the following day was a Monday. So all those who didn't attend church, that was coming from the teacher, a sheep, stand by the side. And those who did, you go and sit down. Is there any reason why you people didn't attend church? And everybody offered. I said I wasn't well. She wouldn't listen. So you know what happened? We had to go through Adanko. You held your ears and then you went up and down. Up and down. As many times as you can.
Yeah.
You know, sometimes, when you are tired, you want to give you a little stimulus by a tap with a cane. And you just, anyway, when that happened, when they let me free, I was going home. It was around about lunchtime. Just as I was getting close to home, my mother had returned from Adum. Adum is an area in Kumasi where the shops are.
Yes, the shops, commercial district.
She had gone shopping and was also returning, and saw her son crying. What happened to you? I was made to do Adanko. So the message was conveyed to my dad when he came home, and he was so furious. The following day, Tuesday, straight to the school, to the headmistress, and gave her a dressing, verbally.
Verbal action.
for mistreating children. And so I was taken away from that school to the government school until I was able to join the group in the main Anglican school. My father was very, very, very disappointed. He was so furious.
I can imagine.
What
was your mother's profession? What did she do?
Oh, my mother was also a teacher. But when she started producing us, I think she spent most of the time helping my dad. When, let's say, there is a sports event, my mother will arrange things that the girls can do. Sometimes we have they call it maypole dance.
British
something like some festivity, let's say celebration of some anniversary. All the schools would do some performance. And my mother used to maypole dancing, where the girls would dance around the maypole and make all sorts of designs or patterns with the variously colored ribbons. And she did. She taught people how to sew things and how to make jam and marmalade.
Really?
Yes.
Okay.
Guava jellies and lemons and all the rest.
Did you learn all of that stuff already? Did you learn it too?
I can't. I don't do it. But my eldest brother, they took it up. And, she was good at confectionery things, jams and marmalades, etc.
I can imagine.
You know carambola, star fruit.
Ah,
You can make
yes.
you can make jam out of it.
Really?
Yes.
Okay. Your mom had all those skills.
Beautiful.
How many siblings were you?
How many?
Siblings, brothers and sisters.
We were 5 altogether. I was number 5, the youngest.
The youngest. Did you get special treatment?
I don't know, but it seems I'm always in conflict with the one immediately above me. we disagreed in a lot of things, and of course I had to be rescued now and then, But the eldest, or the elder ones, the number 1, number 2, we got on pretty well. Number 3, sort of in between, but 4 and 5,
Fighting
we're always at loggerheads.
Were you all males?
All males.
Oh, wow.
No ladies.
That must have been a nutrient.
Fortunately, I had a lot of female cousins,
Okay.
first cousins, so I knew how to handle ladies, as I grew up.
Did you all turn out to be in the medical profession?
No. Number 1 was a medical doctor. He went to St. Andrews in 1947. Funnily enough, he went to Achimota from kindergarten till he finished his 6th form and went to St. Andrews. Number 2, Professor Laing, he did botany, was his special subject, but he was a great mathematician, a statistician, and he ended up lecturing at the University of Ghana, professor of botany. His special interest was genetics, of course. Number 3, also a medical doctor, also went to the same university in 1955. He worked with the Ministry of Health and then later on for GNTC. Number 4 was Group Captain Laing. He was in the Air Force. He went to Adisco and then Tech, and then he went to UK for training. He went into the Air Force. And he died very early at the age of 50, I think 56 or so. And now I'm number 5. So number 1, number 3, number 5, medical doctors. Number 2, doctor of Pepe. And number 4, doctor, yes, Abongo.
I'm sure you had a good time in that
household. we did. In fact, whenever we were gathered together, everybody could recognize we were present.
Yes.
Either we were joking or telling a joke or doing some mischievous thing, that we got on very well.
Were your parents former students of Achimota School? Did they go to Achimota School themselves?
No. My father went to St. Nicholas, Adisco. He went to St. Nicholas School. My mother, I can't remember, she went to some government school in Kumasi. Funnily enough, my mother went to school in Kumasi before secondary, the schools. My father was there. They went to school, early school days were in Kumasi.
So why did you choose Achimota School, though?
Why did I choose Achimota School? Because, number one, he went to Achimota.
Your eldest brother.
As I said, from kindergarten till he finished. And number two, it was close to home. And number three, at this school, people were regarded as sometimes, the ruffians. So perhaps my dad thought perhaps I wouldn't fit in with the ruffians. I needed somewhere they would be a little bit kinder to me, bullying. And of course, Achimota was known for people learning how to play musical instruments, Even though the same thing happened in our disco, but we had rooms for people to practice their instrument, either piano or violin or whatever it is.
Is that where you developed your musical talent in Achimota School?
Yes, part of it. But I was started off by a certain gentleman whose name, I think it was Parkins. He used to work, I'm not quite sure whether it was PW, but his job involved sketching buildings or making...
It's like technical drawings?
How do you call it? Somebody who will make a miniature house.
Oh, okay, model houses.
Model houses,
okay,
yes.
Okay.
He could draw plans, etc. I don't know the name, but anyway, he was passing by a house in Kolegono. My father had just purchased a piano a few months back. So he wrote a letter to my dad asking if he could practice on the piano for a fee. So my father said, no. We don't want a fee. But I have this, we'll let you practice, provided you teach my youngest son, that was me, how to play the piano. So that's how I started. So I was started at home by Mr. Parkins. And one of the tunes I learned was called Monkey Business. A tune by that name. I grew up, even when I was another doctor, and he was still alive. We still play around with that name, Monkey Business. When we are doing some mischievous activity. but in Achimota, I had a proper full-time training. I went through late Robert Kwame, P.C. Behold, the composer of the national anthem.
He was your music teacher?
Yes. And then one Norman Hill. This was when Kwame died. They brought an expatriate. He started me on the organ.
What was Mr. Beho like as a teacher?
Oh, a little bit. He exaggerates a little bit. He used to tell us stories when he was young and in Kita, and he used to go to the beach, and as he would be swimming, a shark would appear and he would swim to the shore. Oh, you tell a story, man. We couldn't find any musical instrument anywhere, so he had a board as a keyboard with the notes, a board. So he would carry this board and he would practice on the board, And then he went to England on scholarship. And he went to Albert Hall. And when he's telling the story, everyone is busy, the ears pointing in the right direction. So and this huge building, about 10 football fields. And all this organ there, and I sat behind it, and I played. And the other thing he used to do, when it's time for my class to attend music lessons, sometimes there may be a delay. The teacher arriving. So we'll be playing pranks in the classroom. And then Beho arrives. The whole place quietens down. Right. So you say, today we're going to have a special activity. Everybody is going to sing. I'm going to play a tune and I expect everyone to sing the tune I play. So we call a student, Kafui Dey, sing for me. And then he'll play the tune. And then Kafui Dey is supposed to sing back the tune. Not, silly boy, go away, out of tune.
Yeah.
And we'll go through. And then it will come to my turn. Laing, sing for me. Then I'll sing. Very good. Give him full marks. At one time, I think he caught me doing something wrong. So I said, Laing, come here. So I innocently approached him. Your father plays the organ. Your brother plays the oboe. But you play the fool. Get off! So anyway, that was Beho, always exaggerating.
Yeah.
And,
But you guys, you must have loved him, the students.
Oh, yes. I mean, we all like a little bit.
Yeah.
How do you call it? Totally?
Yes. Yeah.
Exaggerated story.
Yes. How about
and
sport?
you know his mask.
Yes, he was a big person.
Agbaja.
Yes.
We all had to learn to do it, Agbaja. He was sweating as though he just come out of the sea.
Look at that.
PC Beho. But always exaggerated.
Yeah.
Either in action or verbally.
Indeed. Sports? Were you a sports person?
Everybody had to undertake some form of sport in Achimota.
Everybody.
But yes, you had to partake. But my best one was swimming, a bit of hockey. Football, I could play, but they put me in the goalpost and I was just a sieve. The ball just went through.
You were licking goals.
I couldn't catch the ball.
Yeah.
We played cricket. My highest score was 14. I wasn't very good. I was feared I might be hit with the ball in the wrong place.
Very hard ball too.
But we played every game, cross country. We all partook part in it, even though we may stop somewhere and walk. But we all had to undertake some sport. But swimming, I was good, and diving, and a bit of hockey. Yeah.
Cadets? Were you in the cadets?
No, I wasn't.
No.
I wasn't. The time that they held their meetings, I think it was the same time that probably I would be going to practice my music. But I wasn't interested in that area anyway.
But you were entertainment prefect.
I was entertainment prefect in 1960.
This is like sixth form.
That's right.
Okay.
When I was in the sixth form.
Was it an election or they just said be the president?
I was appointed.
Okay.
I was appointed by the school headmaster and the house of housemasters. I think they usually select their officers, but I was the entertainment prefect.
Why do you think they appointed you?
I don't know, maybe I had a knack. Let me tell you something. We were supposed to entertain the school as final year students, sixth formers. And I decided I would appear as an actor in a Shakespearean play, with a top, something around my waist, and then tights. So the stage opened, and then I walked onto the stage from one side to the other. As soon as I stopped in the middle, laughter. I turned the other. I told you I was wearing tights.
Tights, of course.
And a very short top. So I think they were ridiculing my anatomy, Anyway, what did I think? The song was called I'm Very Fond of Water, and I drink it noon and night. I sang it, big applause, and from that time onwards, anytime I met any classmate, I'm very fond of water.
That was it.
The chancellor of university, Mason, is it?
Ivan
Adamans,
Professor
yeah.
Ivan Adamans.
He was behind me at school, you see. If he sees me now, the first thing he remember, I'm very fond of water and I drink it in the night.
Still remembers it.
No.
Still remembers
So
it.
these are memorable events that occasionally I recollect and see. I've had a good life. You know?
Good fun, good fun. Independence Day caught you in school.
Yes, 1957.
What are your memories of that day?
I knew almost all the heads of states. Kenyatta, Haile Selassie, Nixon, Secretary, Banda, all the heads of state came there, and I saw them.
Oh.
I saw the Emperor of Ethiopia, a very tiny, small man.
They came to Achimota?
Yes, they visited Achimota.
For what?
Yes, 1957.
As part of their state visit?
Yes.
Okay.
I saw all of them.
Did they talk to you or they just came to pass through?
Oh, no, I got that. They were going around.
Okay.
You know,
Wow.
we took pictures.
Who had the greatest impression on you of those heads of states?
The emperor was so small.
Haile Selassie.
Yes, a very, very small man. You know, very tiny. Oh, he had a beard and dressed and all these funny things. You know. But everybody was there, all the African states. I remember that very well.
That must have been quite an occasion, to have all these heads of state coming through your school.
Well, they came in vehicles, you know, and they usually, those who could speak either French or were asked to help by accompanying some of these visitors. But they came to the school, you know, walked around, saw all of them.
Awesome. Great experience.
It is,
Yeah.
it is, yeah. Banda, all of them. Nyerere, Kenyatta, Mandela wasn't then, you
No.
know, but all of them, you know, we saw them. Secretary. It was great, you know. It was Independence Day.
Good times. Did they give you a holiday?
I remember the very night that it was going to be announced at the Polo Club, I was there.
You were there.
Yes, when the Nkrumah, Bedama, Kisile fought, and that's where on the day, whatever it was there. Today, you know, we're
Yes.
free.
You were there.
I was on Polo Ground.
What took you there? How did you get there?
How did I get there?
Yeah.
They gave us a few hours. We all went there.
Oh, they gave you
57. I was 17 years old.
Yeah.
You know, I was there.
What were the feelings? How did you feel when he made that declaration?
Oh,
Because
you
you
felt
had-
great. You know, jubilation. At Polo Ground.
Yes. You witnessed
Before they
history.
built the
Yeah.
mausoleum, of course,
Yeah.
he wasn't dead.
Yeah.
But I was there when he said, today, this will be our national anthem. And everybody will have to stand while the national anthem is being played. And then you could see Kafui Dey still had his hat on until, I don't know whether someone prompted him, but eventually
Take the hat off.
he took it off. But I was there right at the scene, at the Polo Ground, you know, Independence Day.
Wonderful. Part of history.
That's right.
Yeah. That's a
I don't know, it's a feeling of, I don't know what you call it, liberation. Yeah, being part of the process. It gives you some form of, it's a bit difficult to describe. You feel, I mean, I wasn't chained, but you feel you are emancipated. You feel you've achieved something, you know.
You're part of something big.
Yes, yeah. It's interesting, that feeling.
And then 4 years into independence, then you go off to University of St. Andrews.
Yes.
By then, did you know you were going to be? You wanted to be a doctor. You knew.
Initially, even before I reached the the 1960 I thought I might be, if I would go in for dentistry.
You wanted to work on
In
teeth?
fact, my first application for a scholarship was for dentistry.
What fascinated you about teeth?
Because I had experience of visiting a dentist when I was 12 years old. Opposite the post office, there is a story building. If you are facing on this side of the post, you are looking towards Asafwachenete Road with the cathedral.
Yes.
There. On the right, there used to be I think it's still there, I'm not quite sure, 3-story building, and there was an Indian dentist there. That's why my father took me to sort out a hole in my tooth. So that was an experience. And then also, when I was in Achimota, I had some tooth problem. Holiday, so I was given a note to Kolebu. There was a dentist, Kafui. I don't know whether you were born. The dentist, Kafui was.
I wasn't born.
Was related to the Jamestown Manya. And it was Jamestown Manya's house we were living in at Kolegono. Anyway, I was given a note to dentist Kafui. So he sorted out another problem of mine. So I was in contact with the dentist. So that idea sort of came into my head. And for some reason, I think somebody must have told me, he can't be looking into somebody's mouth all the time, for Christ's sake. Do something, where you can either work on the head or... Anyway, I changed my mind. And then eventually, I settled for medicine.
Okay.
I went to the same university as my previous brothers.
How did it work then? You applied and that was it? Was there an exam?
Well, I had a government scholarship anyway.
Okay.
And initially, I was going to be sent to Leeds. My brother was around. He had just come back. My brother was the Scottish University triple jump champion. He was the best student in his class, gold medalist. So was my second brother. So he wrote to St. Andrews that his younger brother has got a scholarship. He's qualified to become a doctor, but he wants me to go to the same university as him. Says, oh, bring him as long as he's qualified. So they took me to St. Andrews.
How did you get there? Was it by sea or by air?
By sea.
Describe that.
First time.
That experience. Where did you take off
First
from?
time, I was seasick.
You were seasick.
I was seasick. I was vomiting all over the place. And then the calm came and we got to, I think, one side of the channel, and now we had to cross on a ferry or something.
Did you take off from Takoradi?
From Accra.
Oh, by the lighthouse.
At that time, there was a strike on. We were taken to the ship by boat.
I see.
Yeah, pardon.
From Jamestown.
Yes.
Area? Yes. Where the lighthouse is.
Yes,
That's where you took off from.
that's right. SS Calabar, SS Winneba.
That was a ship.
It took us 10 to 14 days. We ended up at Dover.
Bobbing up and down for 10 to 14 days. Did you see
I was sick.
any whales?
Oh, occasionally you saw a whale in the distance. They were announced that there's a whale. Yes, it was an experience. I had never left home before.
Yeah.
First time to be put in a ship to a foreign land. But there was a doctor, Dr. Lahiri, who'd been working in Ghana for a very long time. And occasionally he would join I wasn't alone. I was with another Ghanaian. In fact, we were classmates in Achimota. He became Dr. Mills. We were in the same class. So he was in a group, and there were 3 others, Ghanaians. So we used to gather and tell jokes, etc. But Dr. Lahiri occasionally would join us and advise us as to when we got to school, St. Andrews or university, how we should manage ourselves, the books we should read, the newspapers, or the societies, if there are any that we may join, that sort of thing, how to dress, sort of
Some kind
advising
of
us.
orientation.
Yeah.
Where was St. Andrews located?
St. Andrews is the northern part of Scotland, on the east coast.
Which means when
It's
you got
above
to,
Edinburgh.
when you got to England, you had to take another trip all the way to Scotland.
Yes.
By what means of transportation?
Train.
You went by train.
Overnight train, yes.
Sleeper.
Yes. So from London all the way to St. Andrews. It was on the other side, the River Tay. You know. St. Andrews is in Fife and Dundee is in Angus. A beautiful place, old city, very historical, and 3 main streets: High Street, North Street, and Market Street. Very small place. The people there know all the students. It's a small. We were only 52
Students.
in a year.
The entire
52
class.
In a class.
And how many Africans or black people?
2 Ghanaians, me and
Mills.
Tony Mills. The year above, we had another 2 Ghanaians. It was so.
That was
For a
it.
long time, before the medical school started in Ghana, they were taking Ghanaian students too at it every year.
So in the class of 52, you would just be 2 black people?
Yes. No. 2 Ghanaians.
Yes.
But there would be
Other black people.
people from Kenya, Uganda.
What was the experience like interacting with these?
Oh, it was interesting. The Scottish people, because their accent was a bit difficult to follow what they were trying to tell. But later on, we got to follow what they were saying. You know, they were speaking English, but not with the accent that we were familiar with. And in fact, there were quite a number of English people in Scotland, Scottish University, you know, who spoke proper English. But the Scottish people were very friendly. In fact, we had a friend whose uncle was the provost of St. Andrews City. And occasionally he would invite us, by us, you know, Tony Mills, myself, and other, we can call it Commonwealth, to his house for maybe tea, etc. They were very friendly. And you got to know the townspeople, people in the shops, you know, because there weren't many colored people around. And the other interesting thing is every Sunday, you had to, if you went to church, you had to dress up, suit, and you had to wear a gown. And then after church, there was this tradition of walking along the pier right into the sea and back. This was the occasion we used for hunting. You know, in case you were interested in one of the fair ladies, then
Yes.
you had to join in the walk, the pier walk, so
Yes,
that you can spot your fair lady and invite to tea or whatever.
That's it.
So, you know.
I'm sure they took more than a casual interest in the African students. I'm sure.
The usual things the students do.
Yes.
There was an occasion which was very frightening. It was, I think they called it Freshers' Night or something. But all the male students went to female hostels and picked up bicycles that were parked and hung some on trees, etc. You know, or took them somewhere, just left them there.
Pranks. Yeah.
And then the police had to come round and get those responsible. You couldn't find them.
No.
But I was so scared, I ran into a bush close to my hall of residence. So there was I said, my God, if I'm caught by this police and the message gets home to Ghana, what are my parents going to be brought here and you become involved in this nonsensical activity? So that were winter time.
And she was in the bush.
It was frightening. Anyway, nothing happened untoward to me, but they sorted out the rude ones they caught, you know. Yes. That was something worth remembering.
Yes. St. Andrews ended in 1967, but the coup that overthrew Kwame Nkrumah happened while you were in Scotland, 1966.
The coup happened 1966.
Yes.
I was in Dundee, in Scotland.
Yes.
Let me tell you, we had two colleges. St. Andrews University had a college. Dundee had a college, Queen's College, St. Andrews University. You did the preclinical work studies in St. Andrews. That's after the third year, you go to Dundee, where the hospitals are, where you did the clinical work. Mm-hmm. So at the beginning, there will be another number of students in Dundee, mostly dental, because I had a dental school there. So when eventually the two groups came together, we should have been about 100. Mm-hmm. But when we qualified, there were only 65 of us with the year.
Wow.
The two groups. Mm-hmm. Some had fallen by the wayside, or some had either changed course or something else. But only 65 of us qualified as doctors in Dundee.
Were you surprised by the coup? Did you have any? I mean, what was the news you heard about it when you were in Scotland?
You see, when you're in a foreign country, sometimes the interpretation of news, etc., can be quite difficult. I mean, you're a student and people say, oh, Nkrumah is becoming too friendly with the Russians. That's all sorts of things being said about your head of state. You're not there, and somehow you tend to go along the same way. You think, oh, of course, oh, it's good. But then when you grow up and you see the repercussions, and you realize that it was all a mistake. You know, well, the CID, I mean, I said CID. The American Secret Service, they were all involved in it, which isn't good, you know. Mm-hmm. They are not too keen in letting us, you know, develop. I think later on you realize that perhaps we were misinformed, or the wrong thing was said about the head of state at that time.
Indeed. You know. So you returned to Ghana in '68, and then you went to work in...
I did my house jobs in Scotland, in Perth, and in Stirling. And then I came home in '68.
Yes.
I did...
Did Ghana change? Had Ghana changed by the time you come back?
Not much.
Not much, okay.
And I'll tell you, I nearly got in trouble. I had a television interview with Fritz Bafo.
Yes.
Yours sincerely.
Yes.
And I remember saying, oh, maybe that was at a later date. That was in the 90s. I had come home on a visit to attend the funeral. And I had this interview. And I remember saying at the time that Accra hasn't changed, and the portals are still the same place that they used to be. And I believe I shouldn't have said it. Anyway, where were we?
Yes. You came back to Ghana '68.
'68. I think Ghana was beautiful, sweet. I did a few weeks in Rage Hospital, just while waiting for my papers to be signed. And then I was posted to Kafui Teaching Hospital. So by September or so, I think I was in Kumasi. And
as a house officer or a resident?
A medical officer.
Medical officer.
I did my house jobs
up there. So you hadn't specialized yet?
No, I hadn't specialized.
Okay.
So I was posted to Kafui Hospital. Some of the doctors were classmates of my senior brothers, or they went to the same school. So for some reason they thought they could help me out. Anything that was being done, let's say an operation, I'm assistant, they made sure that, you know, a colleague's brother or whatever it was, they encouraged you and they taught you things, you know. And I remember Dr. Agbile, for instance, he was an obstetrician, gynecologist, looking after female diseases. He was the schoolmate of Ebenezer, second professor. So he took me through the various operations. Initially, you just assist. And when you get to a stage, you do the closure. Then a stage will come where you start the operation. You go to a place, you are caught, he takes over. So you mastered it, and then next time he won't come in, he'll sit outside there. Say, you start. When you're difficult, you call me. So you're difficult, he comes in, helps you out. Then time comes, I'll be in Ghana Club. If you're going to do it, let me know first. Okay. So I've got somebody with an ectopic pregnancy or a baby in distress. This is what I've decided to do. He said, okay, go ahead. I'm at the club. So I'll do it. So they encouraged me.
Was training you, yeah.
So I learned a lot.
Mm-hmm.
The same with general surgery. Professor Hiazi, he also helped me a lot. And Dr. Kemava was the ENT surgeon. He was a classmate of number one, also Achimota.
Yeah,
so he taught me a lot in ENT.
Yes,
ear, nose, and throat.
Yes.
Casualty. Orthopedics, if there is any problem with orthopedics, the specialists, they're quite willing to have. You only have to ask, and they will show you the right way to do things. So I got on very well in Kumasi.
I can imagine.
And even before I undertook the postgraduate program, I had picked up enough to be able to survive on my own in the district hospital. Far from Kumasi, I was sent to Bolgatanga.
Did you go?
Yes, as a surgeon.
What was that like?
Great. I was a surgeon there. I was doing all the surgical operations.
What were the most common ones?
Strangulation, hernia.
Why do we have so many hernias?
I don't know why, but maybe it's the, I don't know whether it's a weakness in some part of the wall of the abdomen.
Is it linked to lifting
well,
weights
that's
the wrong
partly
way?
anything that increases the abdominal pressure. So if somebody's got a chronic cough, for instance, or somebody's got difficulty peeing, prostate,
Yes.
and you have to force yourself, you can have, if a small hernia become big, you see, and you have to have the underlying condition sorted out.
What's the size of the biggest hernia you've worked on?
Size of my head.
What? How was the person walking around?
You'll be surprised. Even hydrocele are bigger than pots. When you have collection of fluid within the scrotal sac, can be as big as a pot, flower pot.
So somebody with a hernia the size of your head and the hernia is here?
With difficulty. So you have to concoct a strap, something to strap it to support it.
Wow.
So you can imagine blood flow to that size of hernia getting obstructed. Then you're in trouble.
So, and after you perform the surgery, what's their reaction when they see that the problem has been solved?
Well, it's painful, but at least they are pleased, aren't they?
They're pleased.
To be carrying such a
They
thing.
load around. Yeah.
If you see a hernia, if it's small, that's the best time to
catch it.
to deal with it. Because if it reaches a stage where it gets out and the circulation is shut off, you can have literally gangrene out of it in the sac, and that can kill you.
It's a
Can
serious
kill you,
thing.
yeah.
When did you decide that you wanted to be a plastic surgeon?
This is very interesting. Sometimes it's very difficult to know exactly who sort of persuaded you or who influenced you into going into a particular field. But when I was at King's College Hospital.
In Ireland? No.
This was in London.
UK.
You see, in 1972, an examination was held by the Department of Surgery, Kolebu, to select candidates to undergo some part of the postgraduate training in Ghana. The program itself consists of two parts, a part one, part two. Part one, it will be what we call the basic sciences: pathology, pharmacology, biochemistry, anatomy, basic sciences. If you pass that, then you are eligible to do rotation among the various specialties and then go abroad for your final exam. This was all arranged by the head of Department of Surgery and the Royal College of Surgeons. So they even volunteered to send teachers to help with the teaching the first part. So 5 of us were selected. Some were trained in Scotland for the undergraduate thing. Russia, Switzerland, Ghana, St. Andrews. As the program went on, some departed, they didn't finish, they went their own way. But I passed the primary after 2 years. That was and then we did rotation for 4 years in the various specialties: accident center, general surgery, orthopedics. So in 1976, we had a scholarship from British Council. I was sent to King's College Hospital. Another fellow was sent to Westminster Hospital, and others went to other hospitals. Some went as far as Newcastle. Another chap went to Guy's Hospital, also in London, And that was to undertake brushing up of whatever we learned so that we took the final part. I had my final exam within a year of getting to King's College Hospital. So we got to London 76, 77, I sat for the exam and I passed. My tutor suggested that while waiting to decide whether to go home to Ghana or not, why would you like to help? There is a doctor here who does a bit of plastic surgery. Occasionally, he does it, his private work, at the Royal Masonic Hospital at Ravenscourt. If you want to earn a little money, I can fix you, go help him with his private work. I said, oh, yes, sir. So I was fixed. And there I saw people's noses being worked on, changed, breasts being done, U-shape, and other things. And that was the event that sort of pushed me into plastic surgery. Okay. So I wrote to Professor Bidu that I think I decided to do plastic surgery. He said, very good, very good. We don't have any plastic surgeon in Ghana,
At that time, there were none?
No. There was nobody called a plastic surgeon in Ghana at the time.
Okay. So
the burn cases, which is usually supervised by a plastic surgeon, was being supervised by general surgeons. Mm-hmm. Orthopedics, some of the surgeons could do skin grafts. And some of the urologists, Professor Corte, for instance, could do operations we regard as plastic surgical operations, where he can move a bit of tissue with the blood vessels and use it to reconstruct a new tube for the urethra. Say somebody's got a stricture of the urethra, urinary passage.
What's a stricture?
A narrowing disease, okay. If you have gonorrhea, sexually transmitted disease, and it's not properly treated, you get scar tissue there and it narrows down. So you have to literally remove that segment. Mm-hmm. If you cannot bring the remnants together, then you have to create a tube.
Yes, to connect both.
Yes. Mm-hmm. Professor Corte devised an operation for that, Corte flap. So he wasn't a plastic surgeon, but he was doing a plastic surgical operation. Pediatric surgeons were treating cleft lip and palate. They were treating hypospadias, which is another condition that affects the male genital organ. The opening is not at the tip. It's on the underside? We call it the underside. Oh. And it can be anywhere on the glans or right at the back at the junction of the scrotum and the shaft of the penis.
So that if you peel it would really come from there instead of shooting out.
Exactly. And funnily enough, that's one way of preventing, the old people thought they could prevent pregnancy, by diverting the sperms, creating
downwards
an artificial opening. Anyway, there were surgeons who were working on conditions like this. They were not called plastic surgeons.
Okay, all right.
So I think, I always say, a lot of people, our predecessors have done a lot in certain fields, and sometimes we overlook, we think, we are the organs, but they have contributed a lot before we even appeared on the scene. So what were we talking about?
So that got you into, I mean, Professor Bedu said, go ahead.
That's right.
Because there are no plastic surgeons in Ghana.
The reason being, he trained in Sheffield, and they had a beautiful center in Sheffield. So it was quite easy. He just rang up the head of the plastic unit in Sheffield.
To look after you, you're coming.
We'll take him.
That's it.
We'll take him. So, from London
To Sheffield. How long did it take you to qualify as a plastic surgeon?
Well, initially they said I will be able to manage myself 1.5 years. We made it 4, which is the usual time, you know, that you get a better understanding of and the other thing too is 1982, around that period.
Second coming of J.J. Rollins.
There were a lot of problems in our part of the world, unfortunately. So that delayed my returning home. So I decided to carry on plastic. So I did nothing from 78, plastic surgery. So I went back to my teaching hospital, Dundee. In fact, they had built a new hospital. I did plastic surgery there. Bridge of Fence, another area related. It's part of, shall we say, area covered by the area that covers 9 West Hospital, the new hospital. We include Bridge of Fence as part of the area that doctors at 9 West can go and work. I worked in Bristol. I worked in Billericay near London. I worked in Exeter. I worked in Edinburgh. And I worked in Cork, Ireland, Southern Ireland. I did 3 years in Cork, right, a certain bit of Ireland. And then I was telling you about the...
Yes, the punches in the noses and the cheeks.
So that was... So
you did a lot of
I got a lot of experience, you know, from various eclectic.
Yeah.
So when I came home, you know, I fitted in nicely. And there we are. A lot of politics at the time, of course. But
yes, indeed.
Things settled down, and we were able to have a center that we could all, you know, whether or not you belong to the medical school or Ministry of Health, you could all work in one place, you know, under one roof. So that's the situation now, you know.
Indeed. And so you returned to Ghana in '93.
Yes, as a plastic surgeon, employed by the medical school.
Indeed. And then when did the idea of the National Reconstructive Plastic Surgery and Burns Center come up?
In 1992, there was a visit to Ghana by a group of plastic surgeons. The group was led by Professor Mustade. He was a retired Scottish plastic surgeon who was working in Cannesburn. It's a specialist based in Glasgow, where they trained plastic surgeons. Being the leader, when the group had finished their work, in fact, less than 2 weeks, Mustade promised the head of state that he would help Ghana set up a center, build a center. So funds were mobilized in Ghana and abroad from friends, from corporations, from all sources. And then they erected the building. You've been to our place.
Yes, I have.
It's got several triangular, like pyramids, on the face. So that thing was put up, and it was commissioned 5th of May, 1997. So we did our plastic surgery, shall we say, start from that date, the physical building, 1997. So that's how it started. And I came in 1993. When I came, I had to work in a different theater. And those who were coming, there was a relay of plastic surgeons, some coming for 1 week, some for 10 days. There were a few problems because some of the problems may be left behind. And then eventually, when the center was built, then whether or not it belonged to those coming on shuttle, we all worked under one roof.
You are known for highly complex procedures. I don't go through some of them. Trauma reconstruction. What is that?
Trauma.
Yes.
Well, There are situations when somebody may be involved in either in a road traffic accident or may have a fall, but eventually the person will end up with severe injuries which literally deforms an area. So if, let's say, a hand, for instance, somebody has put his hand into a bread-making machine. So apart from the crushing, there is twisting of structures, bones being broken, nerves being interrupted, blood vessels being interrupted, a whole derangement of the anatomy. And you have to be able to sort things out. First of all, you've got to fix your skeleton, okay?
The bones.
And then the viable tissue, which is where you have to mend them. So knowing the anatomy of the area is very helpful. If you don't, then you don't know what fits what. It's
Almost like a mason or a plumber. It's a combination of different
if
things.
you are joining blood vessels,
Yeah, like a plumber.
2 tubes. But then the tubes must be healthy. If they have undergone a crushing injury, obviously the inner lining will be damaged and clot will fall. So apart from reagents, you have to be able to sort out living tissue from tissue about to die.
And can you see that with your naked eye?
Oh yes, you should be able to recognize what is dead or about to die. For instance, if I make a cut and I look at some part of the skin, if there's no bleeding in that part, it means there's no circulation there.
It's dying.
The skin, I'm sure you've done a little bit of biology, but you have epidermis and dermis, a layer of cells within the epidermis, and then you have another layer we call the dermis. This skin is supplied by blood, and let's say you've mobilized a block of skin. You want to use it for something. But for some reason, you don't see any bleeding in the dermis. You look at it, you can't see any bleeding. It means circulation to the part is not correct.
Not viable.
If it's obviously there, then it will be blue or black, won't it? If it's skin, it will wrinkle. It will be cold. It's not turgid. If you press on it, you can't empty any blood vessels because they're all clotted. Now, if it's living, it feels warm, it's turgid, you put pressure on, the blood vessels are empty of their contents. You take the pressure off, blood returns, and it's warm.
I must imagine that speed is of the essence when you want to save somebody's limbs
Yes.
after the accident.
Speed is of the essence because if you don't restore circulation to the body or to the tissues, they will die. And different tissues can tolerate absence of oxygen different times. The skin is very resistant. Muscle, 2 hours, you can see changes occurring. If somebody ties a tonic in there, there's a lot of bulky tissue here, muscle. If you don't let in blood, 2 hours, you can actually see changes occurring microscopically. Or you can look at the muscle and you see it will start being unable to twitch when you pinch it.
Something is
So, there are things that you can observe with your eyes and things that you can also measure. But most of the time we do clinical work. We use your clinical experience, clinical acumen to assess the situation as to what is dead and what is alive, what is damaged and what isn't damaged. And then the technique you use in doing, you don't traumatize the tissue, you see.
What was the severe facial reconstruction job that you've done? You restored somebody's face back to?
I had I think she must have been about 29-year-old lady, fair-colored lady, involved in a road traffic accident. I think she was sitting close to the window. There was somersaulting of the vehicle, and the face was literally dragged on the rough surface of the road. So there was a big hole here. Here. Part of the scalp was taken away. Skin peeled off there. So only part of the ear was there, but the whole tissue, you could literally look
You could see into her face.
No.
Wow.
There's no tissue here. You were looking into the mouth. Looking into the mouth.
Wow.
Everything is.
It's a miracle that she was still alive.
Yeah.
So
when I was called, the patient was already on the table.
Mm-hmm.
I think there was an orthopedic element, you see, but I was called in to sort out the
face.
The first thing, of course, is to make sure that the patient is alive, and then you may have to plan. Sometimes you have to do the reconstruction by stages. But the important thing is to, what we call, remove dead and dying tissue so that you don't get infection, etc., to complicate matters. So that's what we do, and then we plan. Eventually, I had to move tissue from under her breast. Skin plus the underlying muscle turn out across the chest to this part of the face. And you have to provide a lining, and then the skin will be the covering, and the rest will be the mass. Obviously, there will be no nerve in that, would there?
No.
So obviously, if it's there, a time will come, it will droop by gravity. So all these will have to be planned. You can incorporate a nerve in the block of tissue that you use, but it's got to be done properly. It doesn't work immediately.
No.
You see?
Wow.
So plan, you do a staged operation. There are times that whatever you've put there has got to be debulked. It's too heavy. You remove excess fat, or you may have to tighten somewhere or do something to revise the operation.
It's a lot of construction. How about burns? Burn reconstruction. What are some of the striking cases that you've dealt with?
Burn reconstruction. The burn unit itself, I think, it determines what the outcome of the patient will be. Ideally, the patient should be, if at all possible, in enclosed areas where you just can't walk from outside straight into the patient's room. You've got to take off your outdoor clothes and wear a gown, cover your head, cover your shoes before you approach such a patient. The whole idea is, when you have a burn, the whole immune system is lowered. The skin is a protective layer that has been damaged, number one. And also, the immune system, which will fight bacteria, etc., is also suppressed.
Mm-hmm.
So, what do? So we get a lot of wounds that become infected, and then, depending on the extent of the burn, you have to stage your replacement of the burn tissue, which you do in the form of a skin graft, okay? But there are instances where important structures are exposed, and the only protection you can have for those important structures is to use a bulky tissue we call a flap, okay? But most times, if it's just the skin, with no involvement of joints or cavities, a skin graft will do. Generally speaking, anything above 30 or 40% area of the body percentage burnt is a major burn.
And you've seen more 67?
Oh yes,
80%?
you can have 90%, and they won't survive.
A 90% burn?
Almost the whole body.
It's not going to survive.
You can keep them alive, but they don't survive. It's too severe.
Yeah.
You loosen a lot of fluid. You loosen electrolytes. The immune system is lowered. Appetite is not there.
What's your most satisfying outcome as far as burn reconstruction is concerned?
Well, it's burns that have been mistreated elsewhere. Mistreated in the sense that there was no splintage of the parts involved.
What is splintage?
You put in a splint or a plaster to prevent certain positions being assumed by the damaged part.
Okay.
So in the acute stage, you have to splint them in the process. If not, muscles action would pull in the wrong direction, and they end up either the arm in the wrong place or the fingers pointing in the wrong place.
Yeah.
And some of the deformities are atrocious. You know, this modern Ghana, you see someone with a band, and the hand is like this, walking around.
The June 3 disaster, did you work with any of those burn victims?
Yes.
What was that
That
like?
was incredible.
What was that like?
What was it like?
Yes, working with those severely.
You have so many people that we do what we call triage. People you feel will survive, they are the ones who require the treatment. And it's a difficult decision to make. It's got to be made by the most senior person as to who will benefit from any intervention. We call it triage or triage, you know, sorting out those who will benefit from having something done. If somebody's got 95%, the whole body is bent.
You don't touch the person.
I mean, you are literally not helping in any way. You have no beneficial outcome. But you have a young person fit and 25% burn. If you are lucky and there is no involvement of the respiratory tree, you know, lungs, etc., then you stand a better chance. Because once you've got a burn in an enclosed space, the kitchen, let's say you're using gas and it explodes, the force of the blast can literally force heat or burning furniture or whatever it is. Products of burns, products of combustion will enter your lungs. And you have burns of the respiratory tree, the trachea, and literally you can drown in your own fluids.
Wow.
You see? So that's one thing we have to consider. And the blast injuries, making sure. And if you are able to catch the person early, you can put them on the ventilator. And you do the breathing for them. The capillaries, the blood vessels are leaky. The time comes that the leaking stops. So if you can maintain them alive until the leaking stops, then you are better off. So treatment will actually start when the lungs have recovered. Indeed. Before then, you can't do much.
How about Apiate, the Apiate explosion? Did you work on any of the
Which
victims?
Apiate?
There was a tanker explosion. Yes.
Oh no, I don't think I was involved in that one. Probably some of the patients. Is it near Accra?
No, it's in the regions. East.
So probably some of the neighboring.
Yeah.
Occasionally we have referrals from as far away as Wa and that one.
Is Kolibo the only place with the Reconstruction and Burn Center?
No. We have one in Kumasi. We've got a plastic surgeon in a military hospital, trained by us. Some of the plastic surgeons in Kumasi, they trained under me. We've got people in the north, one or two. We've trained people from Sierra Leone, Gambia, Tanzania. You know, they come for training.
In Ghana, how many do we have now?
Oh, about 20-something. At one time, there were, as I say, probably less than 5 at one time.
So 20.
And at one time, I think I was the only one in Kolebu.
Heavy work. That must have been a lot. How many surgeries do you think you've done?
How many do we need?
No, how many surgeries have you done?
Oh, I can't count.
Where did you stop counting?
I can't count. You start off as a medical officer. You do your house job. House job, you're still learning. But once you become a medical officer, there are certain activities that you can perform. So maybe they'll teach you appendicectomy, so you'll be doing appendix. Or they teach you how to handle an ectopic pregnancy. Instead of the ovum, you know, the union between the sperm and the egg, occurring in the tube and then traveling down into the body of the uterus. It stays in the tube. And then it grows, and sometimes it bursts. or it comes out of the, you call it the funnel-shaped end, infundibulum, and enters the pelvic cavity. So it develops there, and then for some reason circulation is not adequate for it. So it dies, and that's an emergency.
So you have to fix that.
Okay. I've done all those, so I just can't count how many operations
10,000?
I've done in my life.
Wild guess, 10,000?
Oh, I can't count.
You've been a doctor now, a surgeon now almost 60 years.
Almost 60 years.
Yes,
Yeah.
it's 59. That's a lot. I'm just thinking, okay, breaking down, in a busy week, you would do how many operations, average?
Presently, you see, we've got 3 teams. I have my team. Mr. Pencil has his team, and Mr. Ampma has his team. Even the newly qualified young plastic surgeons, they've been put into one of these teams. Mr. Pencil, for instance, may have on his list, on a Monday, maybe 12 cases. There may be maybe 3 or 4 general anesthetic cases, and then the rest may be local anesthetic. Mr. Ampoma may have maybe 2 general cases, and then the rest local, or it's a mixture. I may have 2 cases. A lot depends on the complexity of it. So if I put if somebody sees me with one case, it's something complex. I may probably spend 5 hours.
Yes, on that one case.
But somebody sitting in an office and say, this man, he does only 2 operations a day. No, sack him. That sort of thing. A lot depends on the complexity. As I said, Vito's thing, Karim Vito,
Yes.
Zito. It took 8 hours, one patient.
Yeah, but then if the outcome is successful, that's it.
So it's difficult
to measure. It's a lot of numbers.
And I operate once a day, or once a week, unless my team is on emergency, in which case, for the whole week, any emergency that comes,
you do it.
The team responsible will be.
In your prime, how many operations were you doing? How many days did you have to operate on in a week?
As I said, once a week in Ghana.
Yeah.
I was doing about 5. About 5 general anesthetic cases.
A couple of quick questions. Why is it that surgeons are not referred to as doctor, but are referred to as Mr.?
This is a question posed by almost every interviewer. And the reason is this, I'm going to tell you. Our predecessors, we're talking about a long time ago, those who were suits, 3-piece suits, with a watch with a chain in the side pocket, and a stethoscope, the instrument we use we call it auscultating, listening to the bed sounds and the heartbeats, They were the ones regarded as the doctors. And then you had the other people who didn't dress us, whose dressing wasn't regarded as sartorially elegant, you see. So they will be somewhere, they will be draining abscesses, removing small lumps. They were ridiculed, those who remove the bits and that sort of thing. They are not doctors. They'll call them Mr. So this thing has been carried on over the ages, and now you become a doctor, you qualify as a doctor, and if you want to become a specialist, in other words, to go and lance abscesses or remove lumps or move things around as a plastic surgeon, that you revert to Mr. the title. So you started off rightly by saying the visitor for this particular session is Mr. But if I'm going for a loan, I would I think ask whoever is receiving me to pass on the message to the manager of the bank that Dr. Laing is here to borrow money, not Mr. Laing.
You may get more, or you may get your request approved. I'm just curious. Skin bleaching. Does it affect your work in any way?
It affects the patients. Not to tell you what. Some of the medications they use are steroids. A steroid is a substance that is produced by the body, and in states of stress, certain steroids are removed to help the body withstand the stress. And it's usually the adrenal gland. It's a gland sitting on top of the kidneys responsible for that. Some of the bleaching material also contain heavy metals, lead, etc., mercury. Heavy metals, when they get into the body, they can damage your kidneys or your bone. The patients who bleach themselves, the effect on the skin is that we've got what we call collagen fibers. This is the material that the skin is made of. You've got collagen fibers, elastic fibers, right? If you bleach yourself, somehow there's fragmentation, the breakup of the material for building the skin, fragmentation. So blood vessels, which normally should have support by collagen, they don't have it. In other words, they bleed easily. You tap them and the vessel breaks because there's nothing supporting the blood vessel. So the bruise, if hit somebody with who's been bleaching, you get a bruise bleeding into the skin. What else happens? And this is very important. The normal adrenal gland, which should produce steroids, because you're taking one from outside, it doesn't get a chance to work. So it atrophies, we say. It wastes, or it becomes inefficient. So the time comes that, let's say, you fall into a gutter, you're under stress, trauma. Your adrenal gland should be produced, it isn't. So you have adrenal failure. Literally, you collapse. Your blood pressure drops. And you can die. So when we get these patients who are bleaching themselves, they fall into gutters and the skin seems to have been pulled off like a sock. You have to make sure you support them by giving them hydrocortisone, a steroid. And then you tail it off. You give them by a vein or intramuscularly for a period, and then you gradually reduce the amount given. If not, they come in, you put them on a chair while getting them ready to be sent into the operating room. While sitting, they can literally collapse, and it has happened. They collapse, blood pressure falls, and they die. And then you have the unpleasant duty to call a relation who walked with the patient to theater to say that your relation has passed.
And they'll say, oh, but I just brought her here.
Exactly. Adrenal failure.
From the bleaching?
Yeah. So that's the danger of bleaching.
So you
and of course, altered skin also can develop cancer in it.
Okay, so that if you bleach the skin,
yes,
it becomes altered.
How about, because there has fragmentation of the tissue which builds the skin itself. You get a wound, it doesn't heal properly. Okay. And any wound that stays on for too long, you get changes in the cells. They become malignant. They become cancerous.
Let me ask an obvious question. Somebody with bleached skin, grafting will not be possible. Will it be possible?
The skin is so thin. It's possible, but it's not the ideal situation you want to be. So what we do, if you have we call it a degloving injury. When you fall into a gutter and the skin has been pulled off.
Yes.
As though you're taking off a stock. What is best to do, because the wound healing in such a person is so bad, you dress the wound, clean it, and you dress it till blood vessels form, okay? And wound is clean, and then you can take a skin graft and apply it. And as I said, the skin is so thin.
Yeah, it's so thin.
It's so thin. So whoever is taking the skin graft must be an expert.
Indeed.
If not, you cut straight into the subcutaneous too. You see.
No problem.
But the skin is thin. It's very fragile.
Are gutter
And wound healing is poor.
Is poor. Are gutter injuries common in Ghana? People falling into gutters?
Oh, yes. It happens all the time.
Drunk people or what?
They're not necessarily drunk. Somebody going to the market falls into a drain.
It makes you wonder whether we shouldn't just cover the gutters and save you some of the stress.
That's very simple, isn't it? Remedy, but that's not the case. We're still making open gutters, drains.
Yeah.
People who come from abroad, they are the ones sometimes they are so used to going over covered drains that they get out of the plane and they think, everything is covered. And
they tumble into it.
Yeah, they tend to have those injuries.
So that should help.
You have to get used to walking over holes.
Ghana style.
Yes.
I'm wondering, does the color of your skin affect maybe operations? I mean, there's dark skin stronger than fair skin.
You mean, is there a difference between African skin and
white? Even amongst Africans, darker Africans and then fair-skinned Africans?
No, not as far as wound healing is concerned. As far as wound healing. The color of the skin is due to a pigment. And the pigment is produced by a cell called melanocyte. If you go into the development of an embryo, a newly fertilized ovum, cells in a particular area we call the neural crest. Okay, from some cells from an area of the developing embryo, we call the neural crest, will migrate to different parts of the body. These cells some of them become pigment cells, and they will stay in the skin. Sometimes they don't only stay in the skin, but they may be found around the brain, back of the throat, in some parts of the intestine. Some will form, we call it nuclei, the stations where impulses are generated, stimuli or signals are generated and transmitted. If it's a motor, it will send a signal to a muscle to contract. If it's sensory, then it's the reverse direction. A sense organ will pick up information from the environment and transmit it to the sensory nuclei. We call it the center. We're all the same, black or white, except that the pigment may be slightly different. If you take I think I described the skin epidermis and dermis. If you take the epidermis, the deepest layer of the epidermis, you've got a layer of cells, you see, it's got a very fanciful name. It sounds nice. Stratum germinativum.
I love it.
The layer that germinates or produces the cell, sometimes called stratum basalis, the basal layer right at the bottom. The pigment cells are located in the cells there, amidst the cells that generate, you see. They produce the pigment, and the pigment is distributed within the skin through a tubular system, like a chameleon. So it depends on how dense the pigment is deposited, or how it's dispersed. That gives the color to the, and sometimes the pigment may be slightly different chemically. But as far as black and white, wound healing is the same, unless there is other problem with the dermis, which is the bit which supports the epidermis. There are no blood vessels in the epidermis; they're all confined to the dermis.
Let's talk about emotions now.
Emotion.
Have you ever wept, lost control, looking at the extent of some damage from a patient?
Oh, well, as human beings, obviously, if you see a badly traumatized individual, I mean, you You know, it's a hopeless case. Let's give you an example. A child comes from the United States, a Ghanaian child, for holidays. While here, the parent decides that you have circumcision. And then it takes, accidentally, the gland is taken off accidentally by the one who's doing it. It's a bad accident, isn't it?
Yes. Is there hope?
Very difficult to put back, particularly if there is delay. You're dealing with a small structure.
Have you dealt with reconstructing a penis before? Or reattaching it?
Oh, yes, we've done it before. Adult.
An adult?
Yes.
Where was the cut?
It was right at the base.
No, not at the head.
Not at the head. The
base
at
was...
the root. Yes, he chopped it
What
off.
was he doing? What was happening? What happened?
We don't know whether it was psychiatric frame of mind that he had.
He performed his own surgery on himself? Mm-hmm. Please tell me you were able to help him.
You put it back, but it didn't work.
Wow.
You see, the tissue you have in the phallus is different from other tissue in that the muscle, it's like a sponge. Mm-hmm. And depending on emotional state, you can have blood diverted to the spongy tissue.
Yes.
That will keep it erect. The blood vessels are arranged in a particular manner. Some are very superficial, very close to the skin. But within the spongy thing there is a blood vessel in the center. And everything is enclosed in a coat. We call the white coat, tunica albuginea. It's the wall that contains the spongy tissue. So that one is erect at least, because it limits expansion, isn't it?
Yes.
So you can sort of
You don't want a super erection. Yeah, it's just regular one.
Putting small things together by microscope, it isn't always easy. And as I said before, whenever certain tissues are injured, depending on time frame, within a space of maybe an hour, certain structure would have gone.
Yeah. And some of the surgeries, you do them with the help of a microscope to be able to see, correct?
Oh, we did go into that. The big things that you can observe,
yes,
color changes, the warmth, whether it's wrinkled or you apply pressure, you empty capillaries. These are things you can see. But sometimes it's a mobile structure, isn't it? And you've done anastomosis. Things are moving on. You can put a rod in to make it rigid so that healing would... It's a difficult area to work.
So what happened to him? I mean, after you attached it?
It dropped off. It didn't survive.
Did he survive?
The
man himself?
Amputated,
I mean, the owner of the...
part didn't survive.
But how about him?
Oh, he survived. So he's got a short stump for passing water.
He's able to urinate?
Well, there's an opening. The danger is that if you're not careful, the opening itself may narrow. It becomes stenosed. So we have to modify the opening such that it won't be too narrow. It won't be stenotic so that one can easily pass water.
Wow.
But you have such problems, you see. And when you see a certain state, you don't cry, but you know that it's
almost
the outcome is not going to be good.
Have you had somebody cry tears of joy upon seeing their reconstructed face?
Of course.
What was that like?
Of course. It's like a good example is a cleft lip. We have a gap there. When the operation is over and the mother comes to theater to collect the baby, you see the smile on their face. You see a completely changed face, Instead of looking through a gap to look at the gum or a tooth that is erupting, and flatter normal looking face.
Yeah. The baby is no longer...
Just see the expression on the mother's face.
Yeah.
A sense of delight.
It must be rewarding.
You can just see transformation in their faces.
Are slim people, is it difficult to do skin reconstruction on people with very little flesh on their bodies?
Let me put it one way. No. An obese person, someone with
Excess weight.
overweight, full of fat, a typical woman, Makola, sedentary work, every minute he's picking something to eat and they become bloated up. When they are walking, there's no way they can keep the hands because there's a lot of flesh here and there.
Flapping around.
As though the whole world belongs to them. Working on such people itself is a danger.
Oh, really?
Number one, anesthesia gases become absorbed into the fat.
The gas that's also make them go to sleep.
Okay.
The fat absorbs it.
Quite a lot of it goes to the. So if you are not an experienced, you will have difficulty waking up your patient at the end. That's number one.
Oh.
The mere fact also that you are fat, within the abdominal wall, inside, we've got something called the apron or omentum. It drapes the intestine like an apron. Mm-hmm. And if you are fat and you're lying flat, literally pressing on the contents of the abdomen. So we have the intestines, we have the blood vessels also. So a fat person lying down with all this weight from the wall, from the contents, pressing on the blood vessels, pressing on the intestines, pushing the diaphragm, the partition between the abdomen. You have difficulty in breathing. And if you're not careful, circulation is impeded because blood returns by a vein to the heart. So they tend to get clots also. Clotting.
So
and wound healing is bad.
So are slim people at an advantage?
In a way, yes. If you are slim, it's easy to mobilize, isn't it? So these days, any big operation, early mobilization, for whatever reason, whether it's orthopedic, early mobilize as quickly as possible to get the patient walking around such that you prevent some of the complications of lying in bed. Constipation, chest infections, kidney infections, bed sores, loss of appetite, unable to move your bowels and all the rest when you're in bed.
Couple more quick questions. Obstetric fistula.
Obstetric fistula.
Do you do those operations? Is that within your domain?
It belongs to the obstetrician, but I know what it is. Mm-hmm. You know a fistula? A fistula is just a connection between, we call it epithelial surfaces. Let me explain further. You've got the bladder, right? Behind the bladder, you've got the rectum. Or if it's a female, you've got the bladder. And then you have the uterus, womb, and then you have the rectum. During difficulty in childbirth, where the patient's pelvis is not big enough to allow the head to pass through. The baby is trying to get up, but there's too much pain, and it's not big enough to allow it. So you get literally dying of cells in the area where pressure is being exerted. Death of the cells there. So a communication is established between the bladder and the womb, or sometimes even between the rectum and the vagina. Okay. So instead of let's pass urine, you have maybe feces coming in.
Yeah, so it's contamination.
Fistula. Mm-hmm. And it's literally makes the patient uncomfortable. They literally can't have normal life because they are always not in control of the effluence, you see. Mm-hmm. And it's an area where usually the obstetricians, they do that. They repair it. You have to dissect out there. Sometimes you have to move healthy tissue to insert between the structures, so that you don't have two sore areas, one on top of the other. It will recur.
Okay.
So you have to literally repair the defects and preferably put something in between the two to stop to get rid of the condition.
Have you had a woman come up to you and said she wants a designer vagina? She wants you to work on.
Yes.
What was the procedure?
No, I didn't do it.
You
A
have something
lady
against-
came to me and said, the area there is not symmetrical. One bit is turned that way in there.
How did she know?
No, wait a minute. So I said, who told you this? Was it your boyfriend or your husband? And then there was laughter, you see. Obviously, somebody must have suggested that to her, you see. But I said, I wouldn't do it. Because I don't believe you are going to be exposing your area to the whole world.
Exactly.
So keep whatever. If you want somebody else to do, you can. But I wouldn't. I wouldn't do it.
Was that the only request you had?
Oh, I've had one or two. Sometimes somebody comes and says, the right buttock is small or it's twisted. Can you? And we always ask the question, how did you know?
Because your buttocks are
But
beyond
they always tell you. They hesitate, meaning probably somebody
told them.
suggested that.
Yeah. What other strange requests have you received, Mr. Laing?
At one time, when we started plastic surgery, I had a few cases coming in. They thought we could easily alter the fingerprint on the thumb.
It's criminally minded?
Yeah.
He wants to change his thumbprint.
Literally removing it and putting a graft there.
A different thumb. Like
A graft.
A graft. Why?
Because maybe they have committed a crime and they've got a fingerprint. So they want you to eradicate. Are you with me?
I'm with you, sir. And what was your response to that? I mean, did you have a straight face? Did you have a straight face, or you just?
Oh, I don't do that.
Yeah, that's crazy.
It's criminal.
Yeah. Change my fingerprint for me, basically. That's what they wanted.
I don't do it. Yeah, you have to remove it. Strangely enough, you see, when you have an injury here and you allow it to heal, funnily enough, the fingerprint doesn't seem to change.
It comes back.
Yes.
It's maintained.
There seems to be some control in the area that determines the pattern. Unless, literally, everything is started. But if it's a superficial wound, it will heal. And
the groove comes back. So technically, is it possible to replace my fingerprint?
If you take the whole thing down to bone and throw it away and you can borrow tissue from elsewhere, can't you? And put it there. After all, sometimes we transfer a toe to a hand, can't we?
You have done
toe
that before?
to hand to reconstruct a thumb.
You've done that before?
Oh, yes.
You took a big toe.
A toe.
So the man is walking around
reconstruct.
with his toe is now his.
Yes.
And what happened? And then where did you give him a replacement?
Oh, well, at least you can do some with the hand. You don't climb trees with your foot, do you? But at
Unless
least
you're a monkey.
you need something to oppose the other digits, you see, to work.
And the toe works. It replaces a thumb well.
Yes. Something. Without this, the fingers
you can't do
are
anything.
useless. You need something to oppose. So even if you have a rigid structure here, at least the other digits can. But with nothing here, there's not much you can do.
Is it only the toe that has been used? Have you replaced
Oh,
any?
sometimes the old method was to provide a peg of bone harvested from the hip bone, iliac. You put it there. All right. And then you put a tube. Usually you borrow the tube from the abdominal wall. A tube.
Yes.
And you fit the pole or the peg. You put the tube over it. Over a period, circulation is established between the hand in the tube. And then you can divide it. So you'd have transferred tissue onto the peg. And the next thing you have to do is, it hasn't got sensation.
No.
Okay. Sometimes you can borrow, you see this part of the hand, the radial side, very important. This bit is more important than this bit.
Yeah.
Okay. So you can borrow tissue from here with a nerve. You dissect the nerve with the skin. And then you bring it to the peg.
Transfer it to the peg.
That will provide some form of sensation. But it's not perfect.
Yeah,
That's one way the old people used to reconstruct thumbs. Bone peg covered with a tube, flesh, and later on a nerve with a puddle of skin brought from one digit to the palm to the area.
Good job, Mr.
So as far as the thumb is concerned, even half an inch stump is very useful.
Yeah.
As long as there's something there, it's useful.
Interesting. Let's talk a little bit about yourself. So, is it you went almost 8 to 9 months without being paid? Did
That was a long time ago.
Why didn't they want to pay you? What was the
I
problem?
don't know. It's they said they haven't cleared financial clearance.
Clearance.
No, I don't know, but you employ someone, obviously the person expects to be paid.
Exactly.
The same thing happens year in, year out. People undergoing training as doctors, when they come out, they're employed, they expect to be paid.
Exactly.
So you know in advance
And you paid it.
that you're going to employ them. So as soon as they start working, you pay them.
Indeed.
You don't expect them to depend on their parents. If they haven't got any parents, what do they do?
So were you going up to Ministry of Finance to chase your
I
money?
was. Not only me,
Uh-huh.
late Professor Champon literally had to go chasing his salary.
So you're dealing with the civil servants in the ministry and
I mean, it was embarrassing.
yeah. And they paid.
Eventually. But I mean,
It doesn't make sense.
you expect to be paid
Indeed.
while you're working, isn't it? You still can't depend on your relations to support you.
No.
A doctor.
No. Let's talk about the emotional side of surgery. What is the level of psychological burden as far as people like you are concerned? I mean, we see the image is that you're all calm and under pressure, steady hands, but what's it like in your interior?
As I said earlier on before, there are certain conditions you encounter and you know immediately that the outcome is no good. But you don't show it outwardly. We don't raise our hands or we don't put our hands under our and will. But we know it's a hopeless case. Or somebody who is severely bent, charred. Say somebody, yes, electrocution. Sometimes they are trying to fix an area and they accidentally may touch
A life wire.
a high voltage where they get electrocuted. And sometimes you have to literally amputate the limb. If it's dead, if you don't amputate it, it can literally become infected and the toxins will kill the individual. So sometimes amputating an affected part saves the patient. But isn't it terrible when you have a patient who's lost 2 feet, and he's lost both arms? What can you do with that?
You've seen
I said,
cases like that?
yes,
All 4 limbs gone.
all 4. What do you do?
To
You have to be careful,
Yeah, definitely.
even to look after yourself. Normal physiological activity, you can't.
No, exactly. Become a burden. And
Or let's say you have only 1 foot, rest gone, 2 arms. Some of them, they are taught to use the toes
yes.
to write and to eat. It's not a joke. An adult. Sometimes they go away and they commit suicide. It's an intolerable situation.
It is.
To be in.
And for you, the surgeons, do you, what kind of mental health care do you?
Oh, we have psychologists, clinical psychologists.
Do you talk to them?
Yes, we have clinical psychologists who will be supposed to sit with the patient and find out the patient's fears and anxieties, etc. And then he or she will explain to the patient the situation, how best
To do with it.
to cope with the situation, the steps that the doctors may take. It may not be perfect, but at least it's a way of damping down the sad situation, making things a little bit
easier for them.
For instance, if you lose this bit of the anatomy, we can design a prosthesis that can enable you to walk or even to run.
Yeah.
Once the patient knows that can be done, it sort of eases the trauma, the shock.
How about you, the surgeons? Do you talk to the psychologists?
Well, we have to talk to them.
No, for you, your own care. I mean, don't you get traumatized sometimes?
I'm saying we know the problem, but we don't bring it out. We don't
show
it.
Is that healthy, though? Is that healthy? Keep knowing the problem and keeping it in?
In vain, the surgeon's angry shock. This is the hymn book, isn't it? If the one treating you is already in shock, then the situation is bad. But we know it's a bad situation, but you sort of have to live with it and get on with your work. How do you think?
I do get you. It sounds like
we don't express our disappointment outwardly or hopelessness. We don't do it outwardly.
What personality traits makes someone unsuitable to become a surgeon?
Well, I'm going to give a very good example. I had a resident, someone undergoing training as a plastic surgeon. And then I had a lady patient involved, and I think in a road traffic accident with a scar somewhere. And I decided that I would revise the scar, make it look better, The patient came in with a letter from her lawyer who is acting on her behalf. In other words, later on they're going to claim something from whoever caused it. So, obviously, having seen the patient and examined the patient and decided what to do, how to communicate with the lawyer. And then my resident, trainee, decides to take over the patient. See the patient not during working hours, on a Sunday, in a room somewhere in the hospital, and offer some form of treatment.
Somebody undergoing training.
Under training, doing contrary to what his boss has decided to do. And not during working hours, not at a clinic where there is a nurse to chaperone. You think you will let such a person complete his training?
Did you?
Sacked. He was given a warning, he was sacked. You can't have such a person working with females, doing things contrary to his boss's decision. No.
Is he still a doctor?
He went somewhere, he did the same thing. He went to another country. They kicked him out also there. So you don't, if you see such a patient, there's no point saying, oh, he will reform. No. You're taking a big risk. I wouldn't encourage any such personality to work with me anyway, because he may do something behind my back that I'm not aware.
Yeah. How do you cope with patient deaths?
Death is inevitable, particularly when you are related to the individual, you know. But as doctors, if you have a death, that is natural. Somebody gets sick, you know, someone who's enjoyed life, lived a normal life, and then falls ill and then passes off. To me, the effect on the doctor is less than someone, let's say, who's just come from Germany to Ghana on a holiday, a teenager, and is going to see where his aunt lives somewhere, and as he stands by the wayside waiting for another friend, a vehicle comes to go over them. That's an unnatural death to me, and we can say you feel it more, but you don't express it outwardly. You know, everyone is going to go. I mean, if I'm 86, and in fact, next 30th of April, I'll be 86. If I go, to me, I've had a good life. But say, someone who's just qualified, etc., you didn't even have a chance to practice, and then maybe the only son or daughter is just whipped off. Obviously, it's the effect on the individual. It's more intense, isn't it? Yeah.
It is. Does it irk you that
we become inured, we become
you're used to death now?
thick-skinned.
Are you used to death now?
We become thick-skinned. Not that we don't feel it, but we don't express outwardly our feelings. You know, because it doesn't help anybody, does it? Because you have to carry, still as a doctor, you are bound to come across a similar condition. So you deal with the situation as it is. It's sad, yes, but you carry on.
Can you remember the first patient that died? Or really that really affected you?
As I said,
You
it doesn't
not
affect
sure.
you. You don't.
Yeah, you keep it.
You take it as the thing you face as part of your profession as a doctor.
Do they teach you that in medical school?
No,
they don't teach you that. So that's something you learn by
A
yourself.
lot of things are not taught in the medical school. No, I think modern day teaching, I think they are incorporating these subjects into their training. Particularly those who are doing postgraduate work. But undergraduate, I think we don't put too much stress on that aspect in the undergraduate days.
Right.
Now you've got people who look after patients about to die.
Okay.
Who've been trained to care for them.
Like end of life care.
Yes, end of life care. Maybe they will put you in a hospice, a place built like a hospital, but they are offering the treatment, medication that will alleviate pain if you have pain, or if you have some very serious condition, they will make it better. But it's not cure. You know what you're going to do, but they make your life as comfortable as possible.
Okay. A couple of quick ones before we wrap up. Does it irk you somewhat that public doctors rarely become rich?
Irk me.
Yeah.
Is
Is it annoying?
The thing is, not all the doctors are the same, you know. Not all doctors are. Sometimes you look even at those who are not finished their training, and they run off to go and do a job somewhere, locum, and come, just to earn money. Even though the law forbids that. You got some of them running away from their place of employment, regular employment, to go and do certain things. At one time, to avoid that, doctors were offered what we call the professional fees, many years ago. That was to discourage people wanting to earn more by going out to do that. I don't know. It doesn't seem to work. I don't think we are doing that now. But people go out. There are a lot of hospitals in Accra, and a lot of some of the trainees, some of them haven't even finished though.
And they're in the system.
They take advantage, go and do short locums.
Are we safe, the general public?
But that's unsafe. This is what I'm trying to say.
That's crazy.
It's illegal.
Yeah. So why aren't the people clamping down on them?
Oh, they clamp them. You can't follow everybody.
But they can catch some, Mr. Laing.
But it does happen. People leave their place of employment to go and do a job somewhere to earn more money. And sometimes even the place of work, they will charge a fee as a private patient, as though they are doing a private work. No, not the fees recommended by the institution, but they have their own rates,
schedule. Wow.
Sometimes the figures are astronomical, you won't believe it. And sometimes it's in dollars, which is against the law.
Precisely.
But not all doctors behave like that.
No.
Not all doctors.
What advice can you give a young surgeon or doctor on building a specialty from scratch?
In the first place, the decision to become a specialist in a particular field should be made by you, the individual, not a suggestion or imposed on you by a relation that I want you to follow your uncle or so as obstetrician. Okay. You have to make the decision that you want to become a specialist in a particular field. First of all, you've got to be able to know your limits. In other words, the medical training doesn't make you capable of handling every case. There may be cases that you may find difficult. And this is why you should be able to appreciate a difficult case or something you are not familiar with, to be able to discuss with someone who knows. In other words, you have to be humble enough to know that such a person can help me out with this difficult situation. If you can't do that, then you always put your foot in it. You take on something you can't handle. And before you realize that the harm has been done, sometimes irreversible damage has been caused. So you have to be humble enough. You have to know what you know. You have to know you don't know certain things. And you have to seek for advice if need be. That's
good advice. Road accidents, burn injuries, they bring all these people into your practice. How do we reduce the burden of these things?
As far as road traffic accidents go, sometimes I blame people who build roads. I use a road from Atomic down. It goes through Typhoid Road, which was constructed during one government's tenure. No markings whatsoever since the road was built. And you're going, all of a sudden you see a bit of the road jutting in front of you. In other words, there was a turn to the left. They haven't marked it. So you will be driving all of it. No markings whatsoever, no signs anywhere. Sometimes at junctions, you don't know who is got the priority to go. A good place behind Awudome. There's a junction there, Awudome Road, and there's a road that passes behind the cemetery. If you follow that road, you go to TV Africa, you know. Kolebu itself, the hospital, between the surgical department and the laboratories, there's a road. It comes from the mortuary side. And then it crosses a road which passes in front of the dining hall, which is now been converted into a School of Biological Sciences, and then the dentistry there. But I said, stop sign for those coming this way or for those going. They don't see it. And so they speed across. And I've seen near misses so many times.
Inside the Kolebu Hospital.
Kolebu. There are a lot of places roundabout. Give way to
Traffic.
drivers on your left or car. It doesn't seem to apply in Ghana.
So road safety.
You see, the idea is to get people off the roundabout,
Yes.
at least in Ghana.
Yes.
That's the way it should be. But you coming from out there and the one roundabout, you don't let him come out. And all near misses or hit. I've had my backside hit, I don't know, several times at roundabouts. You know, people coming from the... One time I had a new car, I said, well, I've thought on your one, you know, literally threatening me.
Yeah.
You know.
You've had to take the car away for reconstruction.
No.
Yeah.
There are so many things with the road system. They are not safe to begin with.
Yeah.
Potholes. Or somewhere in the middle of the road, there's a big hole. And somebody, if lucky, may put a stick there. Or they put the cover on, somebody comes to steal it to go and sell the metal. This is criminal. You see? And all these contribute to road safety.
And then the
Lighting
burns.
system, poor.
Very poor.
Poor. Light shining straight at you. If you know dimming, point in the wrong direction.
And most of the burns from domestic accidents, the burns that you take care.
Quite a lot.
Gas.
Gas.
It's gas.
We get a lot of gas explosions. You know, we usually advise that the cylinder should be outside the kitchen. And preferably, we have a tube to connect the cylinder to the kitchen. Whenever you go into the kitchen and you smell anything, don't light fire to inspect anything. Open the windows, let things settle, and then you can inspect. I'm not too keen on seeing burners sitting directly on cylinders.
Yeah.
I mean, if there is a leak, and sometimes, you know what, they put a stone over a leaking valve to control it.
How?
It's dangerous.
So a lot of common sense things just have to be done.
So these conditioned cylinders, they shouldn't be allowed to be sold. They repaint them. You know, after a certain period, you have to discard them and buy new ones. I don't know whether it's 10 years or 15 years, but buying old cylinder which has been reconditioned, I think is dangerous. You don't know what sort of life is that, you see.
That's it.
And these are some of the things that we can do to at least to reduce the burns cases that we have. You light a match before you open you don't open the thing and then trying to strike a match.
Exactly. It's dangerous.
You'll be in trouble.
Yeah.
You see. And any fault, get an expert to look at it. Don't fiddle with it or put a rope or something around it to try and repair it. You know, it's not your profession. And cars, I think people should be more rigorously tested before they obtain a driving license. I mean, you sit at home and somebody brings you a driving license. You're not helping anybody. You're going to be a killer on the road.
That's it.
Cars are not maintained. You see, people ready to go to work, they're sitting in a trotro halfway there, they all get down and they are now trying to fix something. All happening all the time. Wasting passengers' time, being a nuisance on the road. They are blocking road. Oh.
It's crazy. It's frustrating.
And they are using vehicles that are not supposed to be for passengers. They are supposed to carry goods.
Exactly.
Center of gravity is so somewhere else. And the furniture, the seats, They are not the correct type.
Yeah, because they were just
The
fashioned.
dangerous
Yeah,
weapons,
yeah.
literally,
True.
about to cut you into pieces.
Yeah, and give you too much work to do.
Yeah.
Yeah. Before we go, I'm just thinking if Ghana had really invested in reconstructive surgery in the 70s, what impact would that have made on our medical system?
Invested.
Yes.
I take it. Let's say if you take the burn unit, for instance. I wish that we had, as early as possible, put up a proper burns unit. By a proper burns unit, I mean a unit where you can separate off a burnt patient from the outside world, in the sense that before a visitor comes in, as I said before, you protect your visitor from acquiring a disease from the patient or bringing disease from outside the patient. And in places I've worked, you don't have a whole family, 10 people all crowded around a burnt patient with the outdoor clothes, headgear, everything. You just walk from outside to the burnt patient site. And if you have one ward, one patient close to the other, I mean, easy to contaminate.
Jump.
You pass infection from one. I know we try as much as possible to wash our hands, but I mean, literally, when they are breathing, even we blowing our expired air onto the patient. Already the immune system is lowered. We have students coming from all sorts of places coming to learn this university, this Valley View, all come in same pattern. Come onto the wall, the clothes they came in from outside. Uniform they worn from. I mean, how do you keep infection down? Ideally, all soil linen should have an exit. You don't pass through the clean place. A place you pass down, collector from outside. And the spacing should be big enough, or preferably cubicles. And then the precautions I've mentioned, gowning, mask, that will go with hand washing, of course. But you see, sometimes people believe so much in antibiotics. Instead of taking these simple methods, they feel you just administer antibiotics and that's it. No.
It's prevention.
Yes.
And simple measures.
It's very important. So I wish if I had a chance, if I would try it, to try to raise funds to build a properly designed burn ward, but it didn't happen. Because I feel, in fact, I remember a picture of me standing somewhere saying, the burns you need is not it's not fit for a purpose. I said this a while ago, and somebody may take it as but that's the situation.
Exactly.
I wish a properly designed burn ward would have been put up. What else? Well, there are a lot of investment. I've only just mentioned one, burns, but sometimes you need incubators for children premature. Sometimes you need ventilators. People have suffered burn wound and there's an inhalational involvement. Or so sick that you have to do the breathing for them till they recover.
Yes.
It's very expensive, actually, to manage people in the ICU. Everybody knows that. It is expensive. But despite the expense, if you want to get people well, then you have to put in money for this thing, for the workers themselves, and the tools to work with.
Indeed. Does the ICU also suffer from the no bed syndrome?
Or sometimes they are beds, or sometimes they are all occupied. And you have to decide whether or not somebody also needing it should displace someone already on it.
What's the best solution for this no bed syndrome? It's been in the news now for a while.
If it's solvable, I don't think I'll be able to solve it.
Is it that complex?
Well, we can alleviate that situation when we promptly discharge patients out of the hospital as soon as they are well. And sometimes you have patients on the ward, they've been discharged officially, but they are still there. They are eating. They are being cared for, but discharged. They are occupying space.
Well, why is it? If you're discharged, why aren't they going home?
You don't pay, you don't go.
So they're kind of detained.
Exactly. That's a practice. And those who can pay, it should be possible that once the discharge is made, they get away as soon as possible.
Exactly.
Okay.
In your almost 60 years as a medical doctor, surgeon, what's your proudest achievement, Mr. Laing?
Well, I see people, in fact, yesterday,
Yes.
I was in Maxmat, and a certain gentleman walked to me. I said, "Doctor," so I said, "You treated me about 20 years ago. I had keloids." And the face was as smooth as way. In other words, the whole thing he had keloids all over the place.
Those are the raised
abnormal scar that occurs
around the face. Yeah.
I worked on it, and he's free of that. So, as soon as he mentioned keloids, no recurrence. It's a very difficult thing to treat.
They can come back, right?
It can easily come back with surgery, after surgery. So when I heard this, I felt so good. There is another young man who will be about 29. When he was about 5, he had a burn. And I think the parents didn't take him to the right place. Anyway, he came to me when the sores were not healed. So I had to finish up grafting and releasing contractures. He's so well, he's now working in some part of Kolebu as I think he specialized in computers. He's working in Kolebu. When I see him, I know somebody have helped him that. But people I see and they say, "You treated me 30 years ago. What did you?" I say, "I had a client. I don't see any trace." To me, it's
a good job.
It's. I feel good.
Yeah, I can imagine.
When you see somebody you've helped,
yes,
walking around. And the other thing, people have trained. The suggestions I made when they were operating, do it this way. Sometimes I say, I'm glad that you gave such a session advice, how to manage such a case. That I'm very proud of. Some are almost finished this training. Suturing.
Suturing is sewing, right?
Sewing. Mm-hmm. You can do a lot of suturing and make things look good. Because if you're able to bring raw edges together accurately in such a way that no part is turned in.
No overlaps or something.
One raw surface to a non-raw. There's no way you're going to have proper union. There are several tricks in sewing things or suturing. And how to remove redundant tissue. Sometimes you stitch something, there's a bulge on one side. We call it dog ear. The special way of removing the lump without necessarily extending the wound. And if you don't do it that way, you keep extending the wound.
So it just continues.
But there's a trick which I've shown them. They said, craft art. Doctor, thank you very much. He's nearly finished his training.
Yeah.
You see. Little things like that. And I don't know, it's when it's so many, you feel you've done your bit, contributed.
Yeah. Is there surgeons are supposed to have steady hands, correct? Is this still important?
Well, I have very steady hands.
Okay.
I don't know whether it's because I'm not smoking. I used to smoke a lot.
You used to? For how long? What is a lot? What was a lot for you?
1992, I stopped smoking. I saw a red light. I had a problem.
Okay.
So I stopped.
You were smoking a pack a day?
Cigarette. I used to smoke weekends, 40 or 60. Go to a party.
40?
Friday, Saturday, Sunday, I could easily go 60 sticks.
Wow.
You know,
What-
when you have the young girls around and
Yes.
you go to a party, you know, oh God, come on, you know, smoking away and no, that's a
So you
dangerous
stopped, so you stopped
period.
that?
Stop completely.
Okay.
Late nights. When you're young, you can go to a disco, get home at 6 a.m., 8 o'clock, you're assisting your boss. And when they ask you to cut a switcher, you're like this.
Because of the lack of sleep.
And sometimes the beverages, coffee and tea, some people, it makes them very tremulous. You know.
Yes.
They have tremor.
You don't take coffee?
I do, but I won't take tea, for instance, on an empty stomach. If I don't take coffee, if I have coffee, I feel as though I'm frightened, palpitations.
Yeah. I get that too. Yeah.
So one has to find out what suits them, you know, and then keep off the dangerous ones. But I think there comes a time when you need to rest your body before you undertake any activity.
Any regrets in your long career?
I don't think so. I think I chose the right specialty. And from the feedback I've had from either people I've trained or the patients I've treated, I feel I've contributed my quota to healthcare, at least in Ghana. You know. I'm quite happy. It sounds nice when you meet somebody to come to you, say, oh, you did this to me. I think it's nice. It's a nice feeling.
Also. So after all these years, rebuilding faces, limbs, and lives, is there any part of your life that you would like to reconstruct?
Is there any part
Of
of
your life
that I would want
to reconstruct? You spent all
It's
this time
a very
reconstructing.
difficult question. I mean, my understanding of your question is I'm not very clear as to reconstruction of my life. I don't think
Any changes
What-
you would like to make?
what I've been through. I think it was to remain. There's some very interesting bits. No, I can't even tell everything. You see, but
I'm curious. Oh.
I've had some fascinating periods in my life. You know, it was a pleasure to have experienced those periods. You know. A bit emotional, you know. Things that you do feel good, or whatever you do with your pipe feels good. These are experiences that are a bit difficult to express in terms of. It's an emotional part of life.
Yeah. Would you say you are a very emotional person away from work?
Oh, everybody has got some fun. I don't think I'm very emotional. That I see a lady I used to be friendly with walking, that I say, why are you walking? And I am not like that.
No.
Uh,
When was the last time you cried?
the last time I cried,
Yeah.
oh, when I lost my wife, I think 3 years ago in November. It was, I think it was, I took her, she was at home and she was being cared for by one of these healthcare people. They come and they stay and they. But a time came that I had to send her to the nearest hospital, which was Ghan East Hospital. And I knew the one who was looking after the section that they built within a very short space of time during the cholera. Professor Komi's younger brother, he was in charge. So he took her into one of the rooms and were nursing her. And then the funny thing is, there comes a time that they say, go and buy this. They'll go and buy this. I knew which way things were going. And in fact, if you ask around, you find sometimes members of the public complain about the same thing. That the doctors know a patient is going in a particular direction, and yet they keep prescribing very expensive drugs to relations to go and buy, when they know that there is a reason for it. Because if you give up too early, they say you didn't care. That's why the patient died. You see? And then you go the other way. That's also another problem. So anyway, I lost her, and I think Professor Comey rang me and gave me the news. That was when I just shed a few tears.
Yeah.
And then at the cemetery, apart from that, well, a little bit of tear will sort out an emotional problem sometimes.
That's true. May she rest in peace.
Yeah.
Mr. Laing, finally, I want to ask you, is there any Ghanaian doctor or medical pioneer or scientist who has been forgotten that you'd like me to interview after you leave the set?
Living.
Yes, living.
The people that I know, my mates, most of them are gone. That's number one. And even people, some of the old professors who taught me, some were not recognized, but they are gone. The young ones, I feel sometimes they're a different breed. Sometimes they forget that we've passed their stage before.
Of course.
And sometimes you just have to accept that your time is past and carry on, But I really cannot at the moment.
Or even outside of the medical field, somebody whose story deserves to be told to Ghanaians.
I can't think of anyone at the moment. It's a difficult area, you see.
Yeah.
Sometimes you need to give it a serious thought. If you're not careful, you pick the wrong person, and then it becomes
a problem.
I would, in the present state of affairs, not suggest anybody until I've given it a thought, I've looked around, in case I missed a mistake, which is likely to happen.
That works for me. That works for me. Thank you so much. I really enjoyed this tour into your life and your contributions to plastic and reconstructive surgery. And I'm amazed that at almost 86, you're still teaching and still working. Where do you get the energy from?
Well, I suppose I get it from people I'm teaching. The more you mix with the young ones, the younger or fresh ideas that you have. Sometimes you ask a question maybe you never thought of, and then it sets you thinking. The more you react with people, that's the more you feel alive. But if you isolate yourself in a room, I mean, you literally degenerate.
Has AI entered the world
it's a give and take, so to speak. Yeah.
Has AI entered the world of plastic and reconstructive surgery?
When you do ECG trace, sometimes it can automatically tell you if it's faulty, that you've got a condition. Yes. It's all artificial intelligence, making a diagnosis from. Well, it's entering. There are so many things it can use artificial intelligence. I'm not an expert on that, but sometimes one fears that the presence of a professional like a plastic surgeon may have to be forgotten, and you depend on the artificial intelligence. But I don't think that may happen. I think you still need input from people. You know, I think so.
Thank you so much. I really appreciate your time.
Thanks for having me.
It's a real pleasure.
Yeah.
And that's our conversation with Mr. Anthony George Laing. He's one of the pioneers of plastic and reconstructive surgery in Ghana. Let's meet in the comments. My name is Kafui Dey. God bless. Thank you. That was a marathon.
How was it?
It was about
About 1 hour.
2:55.
2 hours.
Yes.
2 hours
Yes.
55.
Yes, almost 3 hours. It's like a little surgery.
That's